Welcome to this enlightening webinar on advancing primary healthcare in Africa with point of care, smart diagnosis, timely treatment. I am Phoebe from Wondfo International Marketing Department, the moderator for today's session, and it's a pleasure to have each and every one of you with us. Okay, so in the diverse African healthcare landscape, we unite today not just as participants, but as contributors to a dialogue reshaping healthcare delivery. The journey towards universal access and improved health outcomes is both challenging and inspiring. Primary healthcare's significance is undeniable, promoting our collective responsibility to explore innovative solutions, bridging gaps, and enhancing well-being. Point-of-care testing stands as a beacon of hope, promising smart diagnosis and timely treatment, regardless of geographical constraints. So before we delve deeper into our discussion, I would like to take a moment to express our sincere gratitude to our co-host, Ethiopian Diabetes Association, for their invaluable collaboration in making this webinar possible. Thank you for joining hands with us. Okay. Now, let's introduce our esteemed panel of experts who will guide us through today's discussions. And we are very happy to have 4 clinical chemistry experts from Ethiopia, Nigeria, South Africa, and Egypt with us to explore how point of care are poised to revolutionize primary healthcare in Africa, ensuring even remote communities access accurate diagnostics. So first, we have Dr. Getahun Tarekegn from Ethiopia, who is the president of Ethiopian Diabetes Association and consultant internist and endocrinologist of Addis Ababa University. Hello, Dr. Getahun. Please say hello to our customers.
Hello, everybody. Hello, how are you? Nice to meet you here. Thank you.
Okay, thank you for joining us. And then we are honored to have Dr. Mabel Charles-Davies from Nigeria, who is the president of African Federation of Clinical Chemistry, past IFCC National Representative of Nigeria, and associate professor from the Department of Chemical Pathology at the College of Medicine, Ibadan University. Hello, Dr. Mabel Charles-Davies. Please say hello to our customers. Hello, Dr. Mabel.
Is she muted, or maybe you should ask her if she's to unmute?
Yeah, but I saw his unmute. Maybe some,
oh, okay.
Not the connection is not stable. Okay, let's wait for her and then we can introduce next experts. Okay. So then we have Professor Rajiv Erasmus, who is the Public Relations Chair of IFCC, Emeritus Professor from the Department of Pathology at Stellenbosch University, located in Cape Town, South Africa, and Editor-in-Chief of African Journal of Laboratory Medicine, the official journal of African Society of Laboratory Medicine. Hello, Professor Rajiv. Could you please?
Hi, everyone. This is Prof Erasmus from Cape Town. I'm so happy to be here, and I would just want to thank Wondfo for inviting me to be part of this esteemed panelist. So thank you once again for the invitation.
Okay, thank you, Professor Rajiv. Thank you for joining us. So, and last but not least, we welcome Professor Mahmoud Rushdi Al-Ansari, the Chief Executive Officer of Arab International Laboratories, and International Accredited Immunology Consultant. Hello, Professor Muhammad. Welcome to join us. Could you please say hello to everyone?
It's my pleasure to be. Yes, hello everyone. It's my pleasure to join this amazing webinar arranged by Wondfo. I would like to present my grateful passion and thanks for every one of you. I hope this day will be okay with everyone.
Okay, thank you. Thank you, Professor Muhammad. Thank you for joining us. And additionally, let's welcome Mrs. Amber, my colleague, our marketing manager from Wondfo International Marketing Department. Please say hello to everyone, Mr. Amber.
Greetings to our professors and all of our audience. Really honored to join this webinar. Hope we can have a productive discussion today. Thank you.
Thank you, Mrs. Amber. Thank you for joining us. So let's welcome again for our 4 experts from Africa and Mrs. Amber from Wondfo. So I think maybe Dr. Mabel will have some connection issues. So let's wait for hers, but we can still continue our agenda. So now let's take a moment to walk through today's agenda. Our webinar will follow a structured flow, 4 expert presentations, 1 total solution introduction, and Q&A session for interactive discussions. So before we kick off our discussions, a quick technical note for everyone. Okay, please ensure that your audio is enabled so you can fully engage with today's webinar. If you haven't done so already, you can find the audio settings. Just click Join Audio at the bottom left of your screen. Additionally, we encourage active participation, and one way to interact with our speakers is through the Q&A feature. If you have any questions during the presentations, please feel free to type them into the Q&A box. I will select a few questions and invite the corresponding experts to answer them during the Q&A session. If you happen to miss any part of the meeting, rest assured that we will be recording the entire session. The video will be uploaded to our social media accounts after the conclusion of the meeting, allowing you to catch up on any information you may have missed. Thank you for understanding. Okay, without any further ado, let's get started our webinar. Hello, Dr. Mabel.
Hello, Phoebe.
Yeah, I can hear you. Did everyone can hear Dr. Mabel?
I had problem with connectivity. Is it my turn now?
Yeah, please turn on your video. Could you please?
Hello, Phoebe.
Hi.
Can you hear me now?
Yeah, I can see your screen now. But let's introduce you to our customers again.
Can you see me now?
Let me check.
Hello?
Oh, you can see her. Yeah.
Yeah, we can see
Dr. Mabel, I think we can see you.
Yes.
Okay.
Okay, over to me.
No, you see, you have to look. Yeah, maybe she's doing that.
Yeah, we honored to have Dr. Mabel Charles-Davies from Nigeria, who is the president of African Federation of Clinical Chemistry, AFCC, past IFCC national representative of Nigeria, and the associate professor from the Department of Chemical Pathology at the College of Medicine, Ibadan University. And hello, Dr. Mabel, please say hello to everyone.
Hello, everyone. Thank you, Phoebe and Wondfo, for inviting me to this webinar on advancing primary healthcare in Africa. Using POCT. Now, the AFCC is affiliated to the IFCC, which is the International Federation of Clinical Chemistry and Laboratory Medicine. And I work in the College of Medicine, University of Ibadan. Now I'm going to speak to this outline, the AFCC, the burden of disease, point of care testing, the role of our AFCC, and I will conclude. Now looking at the AFCC, it's a regional federation of the IFCC, and the IFCC is a leading international community that is focused on advancing excellence in laboratory medicine for better healthcare worldwide. It's made up of 6 regional federations, 97 national societies, 23 affiliate societies, 56 corporate members. And last year was the celebration of the 70th anniversary of IFCC in Brussels. As I said, African Federation of Clinical Chemistry is one of the 6 IFCC regional federations. Others are the Arab Federation, the Asia Pacific Federation, European Federation for Clinical Chemistry and Laboratory Medicine, the Latin American Confederation, and North American Federation. Here you find the participants at the inauguration of the African Federation in 2009. And here you can see delegates from South Africa, Kenya, and Nigeria. These 3 countries that initiated the story of the African Federation. And then in Brussels, down left, we can see some members of the AFCC deliberating on some issues. The membership of AFCC has increased from 3 to 15, and we have AFC membership spread all over Africa. And in terms of AFC structure, we have the AFC Council made up of the board and the representatives of the various member societies. And we can see the red portion there where we have the corporate membership. We are supposed to have a corporate member, but that is lacking on the board. And the emphasis today is on point of care testing. And I'm happy that Rajiv is here. Rajiv Erasmus is here to speak to this topic. He's actually the chairperson of point of care testing in the AFCC. And there are projects that have been initiated, and that is harmonization of POCT policies and training in Africa, as well as establishment of glucose reference intervals. Now, when are we talking about POCT? It's because of the burden of disease in Africa. There is significant loss in health, estimated at over 600 million disability adjusted life years. And there is significant contribution from communicable diseases, maternal, perinatal, and nutritional conditions. But early this month, 2023, there was this report in Nigeria by Oga et al., where it is said that non-communicable diseases now exceed communicable and other forms in Nigeria. Now, why am I talking about Nigeria? Nigeria is the most populous continent in Africa, and whatever affects it can significantly affect other countries in Africa and appear to be a representation of what happens in Africa. Predominantly younger population, the life expectancy of the Nigerian is 53 years. And you have poverty, extreme poverty in Africa. And that will result in limited health resources that will continue to prevent diseases. And so you find continual increase in the burden of diseases. And these resources, because they are limited, cannot prevent disease and cannot enable the management of these diseases. So the situation in Africa is quite pathetic. You have communities that are highly populated, and these are all in need of laboratory services. Unfortunately, we have little or no access to diagnostics at primary health care, even when they are present. And services are unaffordable due to abject poverty. But what is the role of medical laboratories? Generally to diagnose disease, surveillance, disease outbreak investigation, initiation and monitoring of therapy, and research and development. What happens in Africa? This is largely lacking and is due to lack of resources, inadequate diagnostic services, and so there are unmet testing demands. The consequence, therefore, is that you're going to have increased morbidity and mortality resulting from misdiagnosis, over and under-treatment of disease, and this can eventually lead to complications that again cannot be handled. And so Africa tends to resort to point-of-care testing, and point-of-care testing discussed at this webinar is extremely important. And what is it? It's testing performed near or at the site of patient and will lead to possible change in care of the patient. And what does it ensure? It ensures speedy diagnosis at appropriate and for appropriate and timely treatment. Can also dictate outbreaks and controls of rapid spread of diseases. It drives innovation in global health, empowers clinicians to take decisions urgently. I will not have to wait, for referrals, to larger centers. And then can change the traditional setting that we have here of therapeutic medicine to predictive, personalized, and preemptive medicine. Now, what are the challenges? Now, there is the use of POCT in many centers, but we have problem with quality, and the devices are not generally validated for local use. And so there is the importation of reference intervals, and this may inform wrong interpretation. Increasing poor resource will also, enable lack of devices because of the cost of these devices. And generally, these are imported. And so there is need for local production. Is there any hope? That is why Rajiv is here to discuss this topic. What is the role of Africa? You can see this bus in an African country on a dusty road. You can't compare this with properly tarred roads, where cars move smoothly and speedily. But are we going to remain here? The answer is no. We are still going to do what we can and move forward. And there is this quote by Paul Russell, and he said, many people can reach for and achieve excellence. To do this consistently is what separates masters and geniuses from everyone else. And following that, there is the mandate of the African Federation of Clinical Chemistry. And what is it? It has the aim to improve and develop the practice of clinical chemistry through education and scientific excellence, with the goal of improving health and well-being of the African communities. And to do that, we have to ensure excellent and consistent laboratory quality laboratory management system. So need to ensure quality laboratories within the reach of aim, and one day we will get there. Now, we need to validate, even though we have POCT devices from various companies, there is a need for validation and harmonization of these devices for increased use in primary healthcare settings. And the focus in AFCC and also in IFCC is on young scientists. But then we don't need to neglect the older scientists because there is need for training and retraining in order to embrace innovation. And these innovations, as we're going to discuss further, would maintain excellence and overcome emerging diseases. We need to come together, industry, academia, and health professionals need to come together, to ensure the future of laboratory medicine in Africa. And so we need engagement of everyone. We have to ensure flexibility, and we have to actively analyze laboratory data. So in conclusion, I would say that POCT is necessary in primary healthcare on the African continent. It enhances reliable and timely testing for efficient diagnosis of disease and management. There are global digital platforms that we hope would improve what is available at present. But at what cost? Many societies in Africa cannot afford testing costs due to importation costs. And so we need local production. And we also have to know that there is there is need for continual establishment of reference intervals due to genetic, geographical, environmental variations. This is compounded by the general movement and migration of individuals. I wish you a pleasant webinar and hope to hear, the speakers, speak to their various topics. And at the end of the day, we believe that Africa will be well. Thank you very much for your kind attention.
Okay, many thanks to Dr. Mabel for good wishes to this forum. And in her speech, he introduced the importance role of point of care for primary healthcare in Africa. And when we talk about primary healthcare, we have to think of diabetes management in the context of chronic disease management, because primary healthcare has become a central point for diabetes management. In diabetes management, proper diagnosis and timely monitoring are essential for diabetic patients. So now we are honored to welcome our next expert, Dr. Getahun, the president of Ethiopian Diabetes Association. He will share the role of hemoglobin A1C, an essential indicator in diabetes diagnosis and monitoring in the management of diabetes. Please join me in extending a warm welcome to Dr. Getahun. Doctor, please share your screen whenever you are ready. So Dr. Mabel, could you please stop your screening share? Hello, Dr. Mabel.
Hello, can you see my screen?
I think Dr. Mabel should stop the screen share
okay.
first.
Okay.
Hello, Dr. Mabel. Can you hear me? Hi, Dr. Mabel. So just a minute. So does everyone can see the screen of Dr. Getahun?
No, I can't see it. I'm just I'm still seeing Dr. Mabel's screen.
Yeah.
So
okay.
I think she needs to stop sharing. Yes. Okay, now I can see it.
Okay. So can you see it now? Okay.
Yeah, I can see the screen of Dr. Getahun.
Yes.
Okay.
Okay, Dr. Getahun, please start your presentations now.
Thank you, everybody. And thank you, Wondfo, for having me here for today's discussion on diabetes and point of care. And thank you, the audience. So I will be talking about the role of point of care hemoglobin A1C testing in diabetes management in primary care. And this is the outline of my presentation. I'll just speak about epidemiology and impact of diabetes management in primary care, hemoglobin A1C, and the role of hemoglobin A1C as a marker of detecting complications of diabetes, and methods of measuring hemoglobin A1C, point of care hemoglobin A1C testing in the primary care, and I will end up with the summary. It's okay, can you hear me?
Yes, we can.
Yes. So I will go with the epidemiology and impact of diabetes. You know that diabetes is one of the most prevalent NCTs, and it's increasing in prevalence dramatically, and it's considered to be the epidemic of the world. So at the background, type 2 diabetes is a complex disease with multiple comorbidities and dreadful complications if left untreated. And the cornerstone of preventing complications is early detection, early intervention, and comprehensive management, which should include primary care, considering the burden of diabetes worldwide. And the major mortality and morbidity in diabetes comes from atherosclerotic cardiovascular disease, heart failure, and diabetic kidney disease, which all can be prevented by early and timely screening and treatment. So when you see the epidemiology of diabetes, it's one of the largest global health emergencies of the 21st century, and it's in a state of global epidemic affecting every country, age, and group. And the effects and the worst impact, of course, comes in the underdeveloped and developing countries. And diabetes and its complications are the major causes for early days in most countries, and most of the days comes from cardiovascular disease. If we see the epidemiology of diabetes and how it's growing, I think everybody remembers from the ADF data that in 2010, the number of people living with diabetes was 285 million and has increased to 537 million, almost a double in 11 years. And according to the ADF data 2021, around 537 million people live with diabetes, and another equivalent number live with impaired fasting glucose, just making a total of more than 1 billion living with diabetes and pre-diabetes. And it's speculated that by the year 2045, the number of people with diabetes will reach to 783 million in the world. So this is what I've been saying, and over 3 in 4 adults with diabetes live in low and middle income countries where effective utilization of resources is very important. And in 2021, there were around 6.7 million diseases. That is the ADF report, that's the latest report. And this means that once 1 in every 5 seconds, 1 person dies because of diabetes. And you can imagine how many people will die since we start this meeting. And it has caused at least $966 billion in health expenditure. That is a greater than 316% increase over the last 15 years. And as I've said, it's around 541 million people, adults live with impaired glucose tolerance, where the intervention should be very critical because this is the stage where we can prevent development of overt diabetes. And impaired glucose tolerance is also associated with adverse outcomes, including cardiovascular disease. So when you see the situation in Africa, around 24 million adults live with diabetes. That means it's 1 in 22 adults. And we do believe that this is an underestimate because the number expected will be much higher. And it has actually caused 416,000 deaths in 2021. And 1 in 8 live births are affected by hyperglycemia in pregnancy, which is another important area which contributes to the rise in the number of people with diabetes. So having said this on the epidemiology, and just one slide on the diagnosis of diabetes, you know, diabetes is a spectrum of disease ranging from normal pre-diabetes to diabetes. So diabetes is diagnosed by either fasting blood glucose, 2-hour postprandial, 2-hour oral glucose tolerance test, or hemoglobin A1C, which is included as a diagnosis of diabetes in 2010. So we have diabetes, pre-diabetes, and normal. So pre-diabetes is generally a range of 100 to 125. And this is an area which needs great intervention to prevent the development of diabetes. So early detection at this level will be very important. And if we see hemoglobin A1C, less than 5.7 to 6.4 is generally defined as impaired fasting glucose or pre-diabetes. And diabetes is diagnosed when we have hemoglobin A1C greater than or equal to 6.5%. So when you see the complications of diabetes, you know, generally it's known that diabetes is the #1 cause of end-stage renal disease, and renal replacement is the #1 cause of visual loss, and it's the #1 cause of non-traumatic amputations worldwide. And now it's also becoming an important cause of chronic liver disease requiring liver transplantation. So you can see that diabetes affects almost every organ. And by the time of diagnosis, a patient with type 2 diabetes may have 21% of them have retinopathy, 18% have nephropathy, 20% have erectile dysfunction. And all these things because it shows you that diabetes is diagnosed usually late because type 2 diabetes is asymptomatic. So this is to show you the natural history of diabetes, that diabetes causes the complications even before the diagnosis of diabetes. In the range of impaired fasting glucose is associated with macro and microvascular complications. So the earlier we diagnose, the better will be the outcome. So we can see that even in the normal range, there is a tendency to develop macro and microvascular complications, even in the stage of impaired glucose tolerance, I mean. So this is the impact. That's why we are really concerned on treating diabetes. So considering the number of people with diabetes, and especially considering the healthcare facilities in Africa, especially sub-Saharan Africa, it's very difficult to have a tertiary level care for diabetes because of the scarcity of the professionals and all the equipment and health facilities. So nowadays, the notion of just decentralizing diabetes care is becoming an important notion, so that diabetes can be diagnosed early at the periphery, and it can be managed at the level of the primary care. And we believe that is the most effective way of intervention with an effective referral system when complications are detected. So this is the chronic care model, which everybody knows, I think. We have the community and the health systems. So we should strengthen the self-support, self-management support. Self-management education is a cornerstone of improving outcomes in patients with diabetes, because the more the patients know about the disease, the more healthy behavior they follow, the lesser will be the complications. And from the health systems, you have a delivery system, decision support, and clinical information system. So at the end of it, an informed and activated patient at every level of a country or the nation, and a prepared, proactive, practical team. And the interaction of these two will improve outcomes significantly, and that has been shown in several studies. So what's the role of the primary care? You can see this, the joined up care. The first thing is to form the diabetes support team, and early referral and intensive treatment for people with newly diagnosed diabetes. So the primary care should be a site for the diagnosis, a site for primary prevention, a site for educating the public about healthy lifestyle, which we believe will prevent most of type 2 diabetes from occurring. And that should focus on the holistic care. That means holistic care. Diabetes is not simple hyperglycemia. So the patient should be treated as a whole. including other atherosclerotic cardiovascular risks, their behavior, their lifestyle, and their nutrition, all should be focused. And rather than mainly focusing on blood glucose, all should be focused or a holistic approach should be followed. And focused care should be given to certain groups and underrepresented population. And this really shows you how primary care is very important, and especially in our country now we are just focusing on decentralizing diabetes care to the primary care facility, and it's being worked up and it's being effective. So having said this, I will go to the hemoglobin A1C, which is the most important marker that has been shown in history to show an effective intervention with regards to the treatment of diabetes. So hemoglobin is one of the proteins which is bound to glucose, and hemoglobin is a tetramer, which is composed of 4 globulin peptides, 2 pairs, and common globulin peptides are alpha, beta, gamma, and delta chains. And of all the hemoglobins, there are different types of hemoglobin. Hemoglobin A1C is the most abundant hemoglobin form, account for 90 to 95%. So this is the most important type of hemoglobin that has been shown to be an important marker for the control of diabetes. And this has been actually shown, diagnosed by a scientist called Samir Rabor from Iran. And there are actually several awards for this. He was the one to show a protein which is associated with hyperglycemia, where he has detected on chromatography, and that is a wonderful invention which has changed the treatment of diabetes. And if you see the forms of hemoglobin, I will not go into the details of the hemoglobin types and variants, but these are the types of hemoglobins that we have, which may also interfere with the analysis of hemoglobin A1C. That's fetal hemoglobin, adult hemoglobin, sickle cell disease, and other hemoglobinopathies like hemoglobin C and hemoglobin E. This should be known, especially in sub-Saharan Africa, where we have different threats and different diseases, and this could interfere on the interpretation of hemoglobin A1C. And hemoglobin A1C continued, we have different types of hemoglobin A1, A, that's A1, A2, from A1 again, A1, 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 A2, hemoglobin A1B, and hemoglobin A1C, of which the most important for us is hemoglobin A1C. So what's hemoglobin A1C? Hemoglobin A1C is important because it's taken as a marker of glycemic control, because hemoglobin A1C tends to be glycated, that's a non-enzymatic glycation of hemoglobin A1C occurs when the blood glucose level is high. And once this glycation occurs, it usually occurs on the N-terminal of the beta chain, valine. And there are 2 steps in the glycation. One is the first sheet base formation, which is labile, and then there will be a more strong and irreversible bondage with blood glucose. And that once the second attachment occurs, it will remain with the lifespan of RBC. And we know that RBC lifespan is around 3 months. So with the level of raised hemoglobin, it shows you that the control, it shows you the control of the past 3 months, because the lifespan of hemoglobin A1C of RBC is 3 months, and once attached, it will stay for 3 months. So it helps to identify 3 months average blood glucose. It is very, very important. It shows you a long-term control of hemoglobin A1C. And hemoglobin A1C is a weighted average of blood glucose in the RBC lifespan. And it's usually given in percentage. Normally, a very low percentage of hemoglobin A1C is glycated. Glycating means non-enzymatic attachment, but glycosylation is enzyme-mediated attachment of glucose to hemoglobin. So what we are concerned with glycation, that's the non-enzymatic attachment of glucose with hemoglobin A1C. So it shows you the control, not only the control, it also shows you the duration of the control, that's showing the control over the past 3 months, which is very, very important in clinical research. So what are the advantages of hemoglobin A1C? It helps us to assess long-term control. As I've said, it can be done at any time of the day. It's not usually done in fasting or the like. You can do it anytime. It's not usually influenced by diet, so there are little controversies. It's not affected by exercise, and used to diagnose and evaluate control of diabetes. And results is not affected by acute factors, because it shows you a prolonged and stable glycemic control, and it predicts complications. The most important thing is most of the complications and most of the adverse outcomes of diabetes are strongly associated with hemoglobin A1C, as has been evidenced in several landmark and big trials, which we are going to see in the next few minutes. And it's other important thing, it shows you that the adherence, because 3 months, when patients usually the problem with the long-standing disease or chronic disease is a problem of adherence, and this really evaluates adherence as well. So when you do that, there are also, we must also know that there are factors which affect the interpretation. A simple determination of hemoglobin A1C is not enough. You must know what really affects the interpretation of the hemoglobin A1C. So there are several things that affect analytic, that's different for each method. There are different ways of determining hemoglobin A1C, and each of them will have their own impacts. There are several hemoglobin variants, especially in certain specific locations of the globe, which should be considered when their prevalence is high. And the other is biological, the same for each method, but there are biological differences, and there are some conditions that change RBC lifespan, which should be actually known. So some of these are chronic liver disease. Every physician treating a patient with diabetes should be very cautious in interpreting hemoglobin A1C, because there are several things that can affect, that can give you a falsely elevated or a falsely decreased result of hemoglobin A1C. And these things are usually common with diabetes, so interpretation should be always cautious for the clinicians especially. So some of these are chronic liver disease, which may reduce your hemoglobin A1C falsely. You may have chronic kidney disease. The interpretation should be cautious. Some of the things may increase, or some of the things may decrease. For example, uremia may interfere with the assay. Erythropoietin production may affect it. Hemoglobin A1C, hemoglobin may affect it, and if a patient is on dialysis or the other, they may affect adversely, either to the positive or to the negative. They may increase or decrease. The other is alcoholism. Drugs like, for example, vitamin C, vitamin E, may reduce the level of hemoglobin A1C. Long-standing use of aspirin may cause acetylation and may falsely elevate hemoglobin A1C. The other is splenomegaly, which is very common in Africa, especially. When you have splenomegaly, then you may have a low hemoglobin A1C, and when there is splenectomy, the hemoglobin A1C may seem higher than the normal. Age and race, usually the black race tends to have a slightly higher hemoglobin A1C, and people greater than 30 years of age may have also a slightly higher hemoglobin A1C. But these are again controversial. The other things are acute hyperglycemia, severe anemia. For example, anemia, the impact is different. Hemolytic anemia, blood loss may reduce hemoglobin A1C, whereas iron deficiency anemia or B12 deficiency anemia may give you a falsely elevated hemoglobin, because they just tend to increase survival of RBC. And the other is hypertriglyceridemia. Again, it was believed to affect it, but now it's known that a high level of triglycerides will not interfere in the interpretation of hemoglobin A1C. So these are some of the factors, and the others are abnormal hemoglobinopathy. So all these things should be considered in the interpretation of hemoglobin A1C. So having said this, I will. This is the other slide, which shows you that the different factors will affect the interpretation of hemoglobin A1C. So what is the importance of hemoglobin A1C? Why are we interested in hemoglobin A1C? This is because it has been shown that vascular complications are strongly related to diabetes, and intensive treatment can reduce vascular complications. So what is intensive treatment? How do we follow intensive treatment is another thing. So this was, there were people who were looking for a marker which was intensive or good control of diabetes. And as I said, hemoglobin A1C was luckily found to be the one. And studies were then conducted to show how hemoglobin A1C was related to outcome. And the first study was done in type 1 diabetes in 1993. That's called the DCCT trial, and diabetes complications and control trial. And the other is the UK PDS trial. The DCCT is in type 1. And later, the UK PDS was done in type 2. And all of them showed consistently that the lower you reduce the hemoglobin A1C, and the lower will be the complications. For example, in the DCCT, which was actually terminated early, it was shown that when you reduce the hemoglobin A1C by 1%, there was a significant reduction in retinopathy, microalbuminuria, clinical albuminuria, and clinical neuropathy. And this has actually provided a strong hold or a strong evidence that hemoglobin A1C was strictly associated with diabetic complications and addressing hemoglobin A1C to a level that is on target will significantly reduce complications. And the other is the same results were there with the UK pediatrics in type 2. So both of them have shown that a reduction in the hemoglobin A1C have shown significant reduction in retinopathy, nephropathy, and neuropathy, and all microvascular endpoints. And later, even the macrovascular complications were shown to be reduced when the hemoglobin A1C was significantly lowered. And this is to show you how hemoglobin A1C, 1% reduction reduces 21% of all diabetes-associated endpoints. 14% reduction in myocardial infarction, 12% reduction in stroke, and aggregate 37% reduction in microvascular complications. So these two studies have shown a significant impact of hemoglobin A1C, or taking hemoglobin A1C at the point of intervention to reduce vascular and microvascular and macrovascular complications of diabetes. So this is to show you what's happened. Even later, the other studies like the ACWORD, ADVANCE, and VADT have all shown that the lower you reduce hemoglobin A1C, the lower the complications will be. So from this point, that has been shown that hemoglobin A1C is strongly associated with complications. And then they also helped us to set a target hemoglobin A1C where the complications will be much lower. And generally, 7 is the target which is taken as treatment target to reduce especially microvascular complications. But you know that individualization should also occur in patients with diabetes. You can reduce it further down to 6.5, and we may leave 7.5 to 8, depending on the patient profiles that we are treating. So having said this, I will go to the methods of determining hemoglobin A1C. These are, I will just briefly mention them. There are several ways of determining hemoglobin A1C. High performance liquid chromatography. This is the standard which is used in the National Glycated Standardization Program. The others are immunoassays, which use antibodies for the detection of the different parts of hemoglobin, enzymatic methods, calibration electrophoresis, Bornet affinity chromatography, and there are point-of-care instruments. Actually, point-of-care instruments use either of the different mechanisms that I mentioned before. So why these are all machines, bigger machines, but later the issue of point-of-care machines, instruments came. And what is the benefit of these point-of-care instruments is these are defined as clinical testings close to the site of the patient. And it's done usually with portable instruments, and it aims to provide immediate results at the time of patient consultation. And it enables therapeutic decisions to be made at the earliest and decreases patient visits. This is very important because when you appoint patients for a result, not as simple a percent will actually disappear. And most of them may go. So this actually helps in decision-making and convincing patients. And simply use a capillary whole blood collected via fingerprint, and it uses one of the methods that we see. And these are all the methods. I will go to the point-of-care machines later. The other few slides on HB variants. There are many variants that we know and that I have mentioned before. So you should know that there are hemoglobinopathies that can affect your interpretation, and always be cautious with that. And the other is the standardization, because hemoglobin A1C is the most important marker for detecting complications. But the problem was there were different results because that is a very, very sensitive test. And that is a test which is important to make decision making. And where there were several results just varying from the normal, then the issue of standardization came. I think most of the audience here are well aware of it more than me about the standardization and the clinical methods. So generally in 2010, standardization, assay standardization failure was strictly issued, and in 1997, the standardization process began. And in 2010, the consensus statement on world standardization came with the National Glycated Standardization Program. That means because of this, there were a standard test, a standard which is kept in the main reference research laboratory, where standardization can be made from different areas, taking samples and results from different hemoglobin A1C machines. So after standardization, in 2010, hemoglobin A1C was incorporated in the diagnosis of diabetes, provided that the method of doing qualifies the standardization process. There is also another way of standardization, that's the International Federation for Clinical Chemistry. So this is very, very important because hemoglobin A1C results may vary significantly. Standardization has come to the issue, and it was then approved in 2010. And all laboratories which are certified will fulfill the criteria of this central body, or central determining laboratory. So, I mean, the last part of the presentation will be as a point of care testing in the primary care. What's its importance? So, it improves. This is very important that the first presenter has said it. Point of care is very, very effective, cost effective, and it's very important, especially in the resource-limited settings. So we should advocate the use of point of care testing for diagnosis and follow-up. It improves diabetes management and glycemic control, and it's rapidly available. It has high patient satisfaction because point of care testing decreases patient revisits. It offers an excellent opportunity to enhance patients' diabetes education and motivation, and it provides a good point of discussion. That's a face-to-face discussion. Once you see the result immediately, you can discuss about the result, and the likelihood for you to convince the patient is higher. And it's usually cost-effective and very fast. Increased operational efficiency in the primary care space. Specifically, it doesn't need a big gadget or a big laboratory. So it is very, very effective, especially in the primary care setting, where the facilities tend to be lower, both technically and economically. So it reduces patient visits and it improves glycemic control. That has been shown in several studies. So point of care should be advocated significantly. I would say they are very, very effective in the African setting. And this is all that I have, but in summary, primary and community care is increasingly at the forefront of delivering diabetes care, considering its prevalence. It's increasing, its rate of increase like an epidemic. It's very important to decentralize diabetic care, especially the non-complicated ones at the periphery, and to have an effective referral system so that complications related to diabetes will be significantly reduced. And hemoglobin A1C reduced an estimate of an average blood glucose, which is very, very important in the follow-up and prevention of complications. And studies have clearly demonstrated that glycemic control measured by hemoglobin A1C predicts outcome. And most organizations recommend hemoglobin A1C is the diagnosis and follow-up of diabetic patients. This is well known, and standardization is very, very important. And clinicians, especially who are involved in the management of patients with diabetes, should be involved or should be aware of the factors that affect interpretation of hemoglobin A1C. And the point of care technology improves diabetes management and glycemic control. It's easy, cost-effective, and efficient for primary care in the primary care setting. Thank you. And these are some of the point of care machines that we know that this is from Fine Care hemoglobin A1C machine. This is a picture. It is very short, taking 5 minutes, and robust performance evidence, which has accreditation from several standardizing committees. So we can use, there are many point of care machines, but these are the Fine Care hemoglobin A1C machines. And the other important thing where we can use point of care is detecting microalbuminuria. We know that the earlier we detect the complications, the more we'll prevent them before they go to the end stage. So especially this is witnessed in diabetic kidney disease, where you detect the earliest proteinuria and affect and treat it, because nowadays there are several drugs which can reverse or we can halt the progression of diabetic kidney disease, early detection of microalbuminuria is very, very important. And the earliest way to diagnose diabetic kidney disease is to see a leak of protein in the urine. So we know that there are non-proteinuric diabetic kidney diseases, but detecting proteinuria at the earliest stage is very, very important in prevention in the stage renal disease requiring dialysis and renal replacement. So this is also another issue that we should advocate at the point of care technology is just effectively using it. So this can be determined, microalbuminuria can be determined in 3 minutes using point of care machines. And that is very important, added to the hemoglobin A1C. And this is all. Thank you. I'm sorry if I take much more time. Thank you.
Okay. Thank you, Dr. Getahun, for your sharing on the role of hemoglobin A1C in the management of diabetes. So kindly reminder, so if you have any questions, please input your questions into the Q&A box. And during the Q&A session, we will give you the answers. Thank you. So in addition, when it comes to primary healthcare, apart from diabetes management, the management of antibiotic stewardship is also of great concern to us. Antibiotics are often prescribed unnecessarily for wide viral infections, contributing to the global issue of over-prescription. In some regions, easy access to antibiotics without prescription can lead to self-medication and inappropriate use. And C-react protein, CRP, plays a crucial role in antibiotic stewardship by serving as a biomarker. So let's welcome Professor Mahmoud to share the guiding antibiotic therapy using point-of-care CRP testing. So, Professor Mahmoud, please share your screen whenever you're ready. Please.
Okay.
Was it good?
Yes.
Is it published to all?
Could you please?
Yes.
Yes. Good.
Okay.
Please.
Basically, I would like to present again my grateful passion and thanks for every one of you, especially all the member teams for Wondfo. Let's go to the main important point that we have to understand deep inside, which is the guiding antibiotic therapy using point-of-care CRP testing. What is inflammation and what is infection? Basically, we have to understand that not all infections can lead to inflammation, but infection, if it will lead to inflammation, it is crucial to be definitely diagnosed and deep inside to be treated. These are the common symptoms that existing with all the inflammation, whatever the cause, which is the headache, the muscle ache, rash, eye pain and fever, back pain, and joint pain. So we have to understand that the major causes for the infection are the bacteria, viruses, and the fungi. And you know that once the infection will develop and the inflammation will exceed, it means that the body protective response is started to work on. So the pathology here is basically depending upon what's going on considering your immune system, your body defensive mechanism, and the battle that started with the pathogen itself. Here, we can understand deep inside what is the inflammation, as it is a biological response. And anyone that can understand more and more about the inflammation can definitely understand that It is a protective immune response with its all cardinal signs of inflammation in the form of redness, hotness, edema, loss of function, and definitely the heat. In order to understand more and more about this issue, we have to understand that the inflammation itself is a protective immune response in order to localize the infection and prevent its spread, as well as in order to eliminate the harmful pathogen from your body. Basically, here we can understand that the causative agent for the infection may be bacteria, virus, maybe fungi or parasite, and if it can invade your body system, it can lead to one of two results. The infection to your human body may be localized, and it means that your body defensive mechanism is okay while doing, and if your body immune system, and especially the immune response, is not working good, it will lead to the systemic type of infection. The inflammation itself, it means that the alerting sign of the immune system in order to clear out the pathogen and all the symptoms that you will suffer from in the form of the fever and all the pain. It means that a lot of the cytokines are released within your body in order to protect your body from that pathogen. At the end of the day, the result of the inflammation will be in the form of killing and eradication of the pathogen, and you will be okay at this moment, or you will develop the disease with all symptoms and signs, and it will be in the severe form. Here are the common causes of inflammation, and actually all of these may be the cause of the inflammation in the form of cardiovascular diseases, breast cancer, lung cancer, arthritis and joint pain, psoriasis, allergies, eye disorder, asthma, diabetes, as Professor just mentioned before. Everything belongs to the GI system as well as the injury. So the inflammation not only belongs to the infection, because you know very well that the cancerous diseases can also do the inflammatory process. Let's go deep inside the CRP, which is the golden standard in order to monitor and alert our professors and clinicians about the disease itself. Once the CRP is existing and increased within your body serum, it means that the inflammatory process is going on. So now we're gonna talk about the CRP deep inside details, and we will understand deep about the CRP, its clinical application, application scenario, and CRP testing. What is CRP? Actually, CRP is a protein that is generated from the liver, from the hepatocyte itself. It can be released on the stimulation or after stimulation from some T lymphocytes, which will release the IL-6 and IL-2 and TNF. Actually, once the CRP is released within your body, it alerts your body, all your body system, in order to start the battle, in order to localize the infection and eradicate that type. Once the body start to understand that you have an inflammation and start to defense against this one, all your body system will try to clear out the source of that infection and inflammation. And it means that the CRP will gradually decrease in order to be normalized again, and no more CRP will release from your hepatocytes. Here is the schedule of starting the inflammatory stimuli, which will start with the CRP, the amyloid A, the haptoglobin, and fibrinogen. And if you would like to understand more about this issue, after the inflammation or the acute tissue damage at about 4 to 6 hours, the CRP can be detected. So it can detect the inflammatory process very early once the pathology starts to develop. So now we can understand that as early as you are infected and you develop the inflammation, your body will release the CRP. CRP can increase up to 1,000 times higher than normal after effective treatment. And actually, it will return to the normal level 3 to 7 days. When the lesion meliorates, the level of the CRP can be declined again to be normalized. This is the whole range CRP. Actually, the high sensitive CRP, which is crucial in order to detect everything belongs to the inflammation and the infection as early as we can, because you know that the high sensitive CRP can detect a very low level, starting from 0.5 to 5 milligram per liter, while the CRP can start from the 5 to 200 milligram per liter. So if we would like to understand more and more about this one, we can understand that the high sensitivity CRP or the HSCRP can detect the inflammatory process as early as it develops within your body. The whole range CRP is crucial in order to know more and can cover the whole process of the inflammatory defensive mechanisms that generated from your body immune system, starting from the startup of the infection and inflammation itself, till the process and the prognosis that go through or can go through all through the from the startup till the finalization that developed by the immune system. And at this moment, we can detect either your body is infected with bacterial or viral, and what is the load. As long the more the CRP is generated, it means that you develop more and more infection and inflammatory process. This is the most important and the crucial issue within this webinar, which is the clinical application of the CRP. Actually, it can be used in order to detect as an indicator for the infection, treatment monitoring, and observe antibiotic efficacy. So here we can understand that when antibiotic treatment is effective, the CRP declines faster and larger than the white blood cell. Basically, considering the medicine or in the clinical side of medicine, we understand that all clinicians are dependent upon the complete blood count and its findings, especially the white blood cell, if we are going to talk about the infection and inflammatory process. And basically, if the white blood cell count is elevated, so the clinician will go blindly that the patient has an infection. And if it is lymphocytosis, so it is a viral infection. And if it is neutrophilia, so it is dependent upon the bacterial infection. This is the basics of the clinicians. But here we can understand something which is very important, that the CRP is an early indicator before the elevation of the red blood cell. And it is early indicator as well for the prognosis, for the good prognosis if the CRP is declining faster as well. Here, this is the case analysis in order to compare between the viral and bacterial infection and understand more and more about this issue. Here, there is the viral infection to the left, and we are going to talk about the pediatrics, 5 years old baby or male, and actually has all the symptoms of the infection and inflammation, starting at the form of the fever and headache. And the left finding are elevated white blood cell count, and the CRP as well is high. The diagnosis is viral encephalitis, and actually there is no changes considering the white blood cell count. While when we talk about the bacterial infection, you can detect that the treatment will depend upon the antibiotics if we can detect the elevated CRP and white blood cell. Here, we can say that the white blood cell either elevated or not, we can be guided in order to use the CRP as an indicator for the infection and the inflammation, and at this moment we have to start the usage of the antibiotic. If you would like to talk and guide the GPs, especially within the primary care setting and the clinical department, especially in the emergency room, we have to apply the CRP. So let's go to the GP and what they have to do considering the antibiotic prescription. And it is a very, very important slide in order to go deep inside and clarify more and more about this point. Here, if the patient does not have any complicated RTI, respiratory tract infection, no further testing, and actually low risk for pneumonia is subjected, and antibiotics are not indicated. While when we talk about the complicated RTI, there is a suspicious for pneumonia. And if we're going to talk about the moderately ill patients, we have to use the CRP, and this is the cornerstone in order to go through this point. If it is less than 20 milligrams per liter, so there is low risk for pneumonia and no antibiotic are prescribed. If it is more than 20 until 100, so there is a clinical prescription for, there is a clinical presentation for pneumonia, and here we can say the usage of the antibiotics may be useful. But if it is more than 100, you have to have antibiotic in your prescription. And definitely you will not go through the treatment without prescribing the antibiotic. So here we can understand more about the usage of the CRP as an indicator and the guiding for the antibiotic itself. Basically, you can use the CRP as a guiding line and light, as well as if it is high, you can go through the antibiotic policy and you have to apply the antibiotic and the antimicrobial stewardship. Otherwise, it will be very, very, very useful in order to avoid the antibiotic if it is very low or less than 20 milligrams per liter. This is some Lancet. Here, there is some Lancet Global Health published papers from Thailand and Vietnam. And here we can say that the effect of the point of care C-reactive protein in testing of the antibiotic prescription, either in febrile patient attending primary care in Thailand and open label randomized controlled trial.
Yes, me? Yes, sorry, Professor Mahmoud, you can continue. Sorry for that.
Within Vietnam, there is a point of care C-reactive protein testing to reduce inappropriate usage of antibiotic for non-severe acute respiratory tract infection among the Vietnamese primary healthcare. So these are already published two papers from Thailand and Vietnam in order to guide us and know more and more about the usage of the C-reactive protein, either to guide you to use the antibiotic or not. So here it is a very important question. Why can CRP guide antibiotic prescribing in primary care? Every one of us know very well now that the antibiotic or the antimicrobial stewardship is not applied all over the world in its standard type. And unfortunately, the usage of the CRP is not well known among all the countries in order to use it as a guiding line and light as well for the usage of the for the antibiotics. So here we can understand the answer now, as it is the bacteria and the viral infection with primarily differentiated using the CRP, closely related to the severity of the bacterial infection, is either it is self-limited or not. So if it is self-limited, so you are not in need for the antibiotic and you will save the the antibiotic either as a money or as a complication, and its side effect belongs to the patient. The low price usage of the CRP, because you know very well that the CRP its cost is very low, belongs or in order to be comparable with others with other lab testing. The point of care CRP is important in primary care. Why? Because actually it facilitates the diagnosis, onset, instructing the use of antibiotic, reduce the antimicrobial resistance. And nowadays, worldwide, you know very well that a lot, every day, more and more antibiotic resistance can be detected among all patients in different countries, even in the well-developed countries. And you know that nowadays we can isolate a lot of multi-drug resistant strains that could not respond to any of the antibiotic that existing nowadays on the earth. So you can find that there is an extended spectrum drug resistance staph. You can detect the extended spectrum beta-lactamases, and every one and then we can detect more and more bacterial infection that could not be treated and could not be respond to the antibiotic. That's because of the poor usage and unfortunately non-application of the antimicrobial stewardship. Here there is some UK guidelines for the pneumonia, especially in adult after the diagnosis and management, and as well as there is different papers that is generated and already published within the Lancet Infectious Disease and Lancet Global Health. As you can see that the country that employed POCT CRP in primary care setting is very little, and we have to have the POCT CRP in more extended spectrum all over the world. We are in need for. These countries that are in use of the POCT CRP in primary care setting actually are in lower level of the usage of the antibiotics, so we can save our weapons against the pathogen. What are the clinical departments that we can use the CRP, or it can be applied? Actually, among the pediatrics, especially the neonatology, as it can detect the meningitis and neonatal sepsis. We can use it in the cardiology, as it can detect the cardiac diseases and the coronary heart disease. We can use it in the ER, the emergency department, as a rapid diagnosis and the predictive prognosis as well. Surgical department as a very important key in order to identify the post-operative infection, especially the surgical site infection and burn. It belongs very well for the pediatricians, as it can detect the acute respiratory tract infection, especially in children, and discriminate between the upper respiratory tract infection and the flu. Considering the respiratory department, considering the bronchial asthma, upper respiratory tract infection, now you can understand that for the current situation worldwide, we have different pathogen belongs to the upper respiratory tract infection, starting from the Haemophilus influenza bacterial infections, Strep pneumoniae, Staph aureus, Streptopyogen, a lot of bacterial infection that can infect either the pediatrician, the pediatrics, or the adult as well. Actually, the CRP can be used in order to diagnose the acute osteomyelitis and severe rheumatoid arthritis, and we can use it as well in the nephrology, especially the crescent nephritis and the primary nephrotic syndrome. Let's go to the CRP testing itself, and now we can talk about what Wondfo do for us. Actually, Wondfo do something amazing, which is the wide range CRP. So we can start to understand more and more about the start of the infection and inflammatory process and we can follow up the case in order to understand what is the prognosis. Actually, the wide range of the CRP that Wondfo generate can understand the pathology of the disease itself, and we can told the clinician about the importance of the usage of the CRP. So now we can stop the antibiotic, or you have to start the antibiotic, or you are not in need for the antibiotic. Very simple and very easy. Just you have to collect the sample, then you add the buffer, then the cassette, and finally within the machine to be read it. 3, and finally 4. Very easy. The CRP clinical application, and this is the most important point that we have to understand: monitor the condition, antibiotic efficiency, identify bacterial and viral infection, cardiovascular diseases, monitor infection. Wondfo advantage: it is very quick and accurate results. Very easy to be used, stored at the room temperature, small sample volume, Wondfo quality control, and multi-departmental application. Finally, again, thanks for everyone that let me join this amazing meeting, and thanks for Wondfo team.
Thank you. Thank you, Professor Muhammad, for sharing your professional views on guiding antibiotic therapy using point-of-care CRP testing. So after listening to 3 experts talk about the important role of POCT in primary healthcare, including HbA1c in diabetes management and CRP in antibiotic stewardship, we found that point-of-care also has some challenges in the process of application. And Dr. Mabel also mentioned global digital platforms, machine learning, and artificial intelligence. So next, we would like to invite Professor Rajiv Erasmus to give us detailed introduction of the role of connectivity and digital transformation in facilitating point-of-care testing in Africa. Professor Rajiv, please share your screen whenever you are ready, please.
Yeah, thank you so much. I'm ready to share the screen. Just 1 minute.
Okay, please.
Okay, that's it. Huh? Where's the first slide? Yeah. First of all, thank you so much to Wondfo for inviting me to give this talk. Just a form of introduction. I'm based in Cape Town, and I'm with Stellenbosch University, as well as the University of Botswana in Gaborone, and also with the Biomedical Sciences at the Cape Peninsula University of Technology. And I'm also the Public Relations Chair of the International Federation of Clinical Chemistry and Lab Medicine, which is the IFCC. And within the IFCC, I also serve on the point-of-care testing committee. And as Dr. Mabel said, I'm also in the AFCC point-of-care committee as well. So I wear different hats. I'm also the vice president of the College of Pathologists of East, Central, and Southern Africa. And I will be talking on the role of connectivity and digital transformation in facilitating point-of-care testing in Africa. So I think I will just first of all start by saying that connectivity is extremely important. Because the accuracy of tests and their monitoring of the instruments is vital to actually monitor the quality of your results. And you will appreciate that if the quality of the results obtained by point-of-care testing is not accurate and precise, it can have an effect on the management and diagnosis of patients who are undergoing that particular testing. So what I will talk about is connecting communities in Africa, the role of connectivity in quality management systems with respect to regulatory compliance. And of course, just before that, I will talk on the role of intelligent connectivity and Internet of Things. And finally, I will wrap up by talking on the role of connectivity, data management, and its impact on P4 medicine. And of course, embedded in all this is the use of digital transformation and artificial intelligence in using the data that is generated by point-of-care instruments. And once you integrate that data, what sense do you make of that data in its having an impact on what we call as personalized medicine or precision medicine? So I think right from, I think why point-of-care testing is so important in developing countries, specifically Africa, is that a recent Lancet Commission review revealed a lack of access to diagnostics at the lowest tier of the healthcare system, which you all know is the community. And in fact, what they reported was that at the community level, only 47% have access to diagnostics. And if you look at, so this is just an average value that they gave, but if you look at Africa in particular, I suspect that the figure is much, much higher, because we have a lot of rural populations in Africa where you don't have diagnostic labs, and that is where point-of-care testing is critical, because in having point-of-care testing facilities in those areas allow for more equity with respect to diagnostics. So let's just look at the differences between between tests carried out in the lab and tests carried out outside the lab. So if you look at what is happening in the labs, what you find out is that, first of all, the distance between the labs and where the testing where the samples are obtained is considerable, whilst with point-of-care testing, it's done on site. So this obviously has a big impact on turnaround times, but the risk to the quality of the results obtained differs between the lab environment and the point-of-care testing environment. And the reason is very, very simple. In the lab, you have quality management systems that are there as part of accreditation standards. Whilst with point-of-care testing, at the moment, that risk is massive, because the quality management systems very often, especially in developing countries, don't exist. And this is where connectivity can play a critical role in improving the quality of point-of-care testing. So you can see on the extreme right that when you look at tests being carried out in the lab versus point-of-care testing, you find that you have very good quality management systems in place, but in the lab, but with point-of-care testing, this is not existent. So what has happened in the world of point-of-care testing has been the power of technology. So recent advances in technology have enabled point-of-care testing to change the health landscape. And this is really of big advantage to countries in Africa, where very often, as I said in my earlier slide, communities don't have access to diagnostics. And in recent times, self-testing and personalized medicine have emerged and are continuing to change the health landscape. So what do we really mean by this power of technology? And you will all appreciate that in recent times, we have what we call as intelligent connectivity. So if you look at what do we mean by intelligent community, it is simply the fusion of 5G, artificial intelligence, and the Internet of Things. And this has happened pretty rapidly in the last 5 years. So if you really look at what is happening, even though it says tomorrow, in fact, it's happening right now, because this slide was taken somewhere in 2018. So what is now happening is that we are in the 5G era, where we have what is called as interoperable networks. In other words, networks that are able to connect with each other. And what this means in practical terms is that you have an exchange of information that is occurring at a regular interval. And then connected to this is what we now have, or what we now call as artificial intelligence. And it's actually become a buzzword. Everybody now knows about artificial intelligence. And what it simply means is that we now have that computational power to integrate data. And this is massive data. When we talk about data, we're talking about demographics, we're talking about social information, we're talking about results from your lab tests, all of them being integrated. And you can imagine just one person can generate a huge amount of data. But just imagine if that information is now using more than 1 million people, the amount of information that is there is massive. And because we now have this power of technology to compute this massive or big data, we need artificial intelligence to make some what will you call a process to interpret that data. And what has also happened is that this data is now being generated through what we call as Internet of Things, in which almost all of us, including our machines and diagnostics, are connected. Obviously, this means that the amount of data or information that is generated on a daily basis is extremely massive. And this indeed is changing our behavior. So this whole process actually started in the 1990s, where it first had what we called as human-to-human interaction, in which we had fixed telephony and text messages. It then progressed to what we call as Internet of Content, which simply meant that we were exchanging emails and we had static web pages. And then it progressed to Internet of Services, in which we had smart IT platforms and e-commerce. As you know, that has really become very, very important in the recent times. And in the last 5 years, we have what is called as the Internet of People, in which we have high-speed mobile broadband and smartphones and tablets. And this is where your 5G has become very, very critical in exchanging this information at high speed. And finally, just 4 or 5 years ago, we now have what I was just talking about, which is the Internet of Things, in which smart devices such as your point-of-care instruments, biosensors can all get connected. And through artificial intelligence, this is enabling what we call as automation of tasks. So this is where we are presently, and no doubt this is having a huge impact on the health landscape. So some of the ways that Internet of Medical Things will impact healthcare is, of course, it is decreasing costs. There's improved diagnosis, faster diagnosis and treatment, which of course is leading to improved diagnosis, disease management. There's also remote monitoring of chronic diseases as well as acute diseases. As you know, during the COVID era, point of care testing and connectivity and the Internet of Things enabled healthcare administrators and managers to monitor and trace patients with COVID. And you could see that it actually led to very, very rapid diagnosis and triaging of patients in the hospital. And of course, this was very much integrated with enhanced patient experience and obviously with quicker diagnosis and faster turnaround times. It actually led to improved drug management of these patients. So let's just talk about what is really connectivity in point-of-care testing. So it's really a process that enables point-of-care instruments to connect with the lab or hospital information systems and link all this information with the electronic health records via a data management system, also known as middleware. And this middleware communicates and integrates real-time data that is generated from these multiple devices that are all connected and databases, and integrates all this information into a single comprehensive solution for data management. So effectively, this middleware is integrating all the data that is available from different sources for a patient and integrates this into a single report such that the medical practitioner has all this information so that effective management or disease management can take place. And of course, all this has been facilitated over the last 10 years on the availability of an open access data management system, which indeed has been critical in making various instruments from different vendors to communicate with each other. And this connectivity presently is the safest and the most reliable method of data transfer. No doubt it reduces the time, eases the burden, and minimizes errors related to point-of-care result documentation. So you would realize that in many third world countries or developing countries where connectivity is still not available, you have manual recording of results. Many of these results are put on sheets of paper, and many sheets of paper often get lost. So many results are being generated where the doctors have no access, especially to results that have been generated earlier on using point-of-care instruments. So no doubt with the availability of connectivity, all these values and results are automatically accessed and are put into a central database and linked to the electronic medical records of that particular patient. So indeed, in the last 5 years, the use of connectivity and data management systems, wherever it's possible, they are recommended for all point-of-care testing programs by national professional bodies. So this just shows diagrammatically what is connectivity. So you see on the left-hand side, you have different point-of-care instruments placed in different units. And what your data manager allows, which is on the right-hand side, is for all this information to be stored into a data manager, the point-of-care data manager, which is communicating with these point-of-care instruments in different locations. And through this connectivity, it is able to integrate all this data and then liaise with the lab information system, which in turn can also liaise with the hospital information system. So this allows for access to all information and tests concerning a particular patient. So connectivity, therefore, is allowing for better integration and management of lab results, which in turn is leading to better disease monitoring and management of patients. So one of the things that connectivity is also having a big impact is that the efficiency in the care pathway is affecting the clinical outcome and therefore providing value for the patient. Because at the end of the day, we need to ask, why are we doing these lab tests? What is it that we want to achieve? And the clear answer to that is patient care. So everything that we do has an impact on patient care, and this is also related to the cost of generating those tests. Obviously, when you have a quicker availability of results through connectivity of the lab or point of care testing results with the hospital information system, it improves the processes and workflow management, which eventually leads to decreased costs. So there was a study done in Ontario, Canada, just about 3 years ago. And what they found out that if you compare point of care testing with testing carried out in the lab, point of care testing had the greatest number of non-conformances. So what does that mean in practical terms to the people who are listening? It means that point of care testing, if you looked at all the processes that were being carried out by the point of care testing operators, you would find that when you compare them with the lab, you find that many of the operators were not following the correct procedures. So what we call as non-conformances. And therefore, this is why a quality management system is critical, because if non-conformances are occurring in point of care testing, the doctors need to be assured that the results that they are that are being obtained through these instruments are of similar quality to those obtained in the lab. So if we look at the point of care examination process, you will find that it consists of roughly 5 areas. So the first thing is where the test is ordered. And following the ordering of the test, we have what we call as the pre-analytical phase, in which you have sample collection, patient and sample identification. And then we have the analytical phase, in which the patient's ID is confirmed, and also if the operator is competent enough to carry out those tests. And following that, you have the analytical phase. And during the analytical phase, issues such as EQA, which is the External Quality Assurance program, as well as the internal quality controls, are put in. Now, very often, many of the point of care operators are not aware of this. And this is critical, because the same quality management that is put in the lab should in fact also be operated in the point of care testing environment. And of course, post-analysis is the storage of the results and also interpretation of those results. So it's very clear that these are the areas that need to be managed effectively for a good and accurate point of care testing service. So the main objectives of monitoring such point of care testing would be really to keep the error rates low. And that is extremely important, because point of care testing is has a lot of error rates. And if the error rates are high due to poor competency of the operators, it can have a big effect on the quality of the results. So one of the big roles of connectivity is really error prevention by providing an efficient quality management system. And as I showed you in the last slide, you have three phases. You have the pre-analytic, the analytic, and the post-analytic phases. And in each one of them, the connectivity allows for monitoring of each of these phases. So the internal quality control processes involves three integral parts of that plan. One is the quality control plan, the other is the quality assessment, and the third one is the risk assessment. Obviously, we will start with the risk assessment first, because in the risk assessment, you assess the risk in each one of those testing processes. In other words, you look at the risks in the pre-analytical phase, you look at the risks in the analytical phase, and you also examine the risks in the post-analytical phase. And this is where connectivity plays a critical role in managing each of these three respective areas that form part of your testing process. So one of the areas that connectivity plays a critical role is in regulatory compliance. And just for the benefit of our speakers, point of care testing is also regulated by what we call as the ISO 22870, which has laid down some of the regulations that govern the operations of point of care testing, especially in a hospital environment or in a healthcare facility. So it's very clear that connectivity here can play an important role in quantifying the patient demographics, in quantifying and recording all the quality management procedures that are undertaken by the operator. They also monitor if the operator is qualified to do those tests, and all these can be monitored through an effective connectivity open access system in which different instruments that are placed in the hospital can be effectively monitored automatically. So just imagine if you had 500 point of care instruments at different points in a hospital. How can you effectively manage them in real time? Now, if you are using a manual system, this is not possible. You cannot monitor 500 instruments in real time using a manual system. So in many hospitals, for example, earlier this week, I was in Amsterdam, and I happened to visit one of the hospitals, and in one of the hospitals, they had more than 1,000 instruments, point of care instruments, located in different locations within the hospital. Some of them were in the clinic, some of them were in the emergency department, some of them were in acute care, and so the challenge really is to monitor the quality of results produced in real time. And this is where connectivity plays a critical role in real time by monitoring all the processes that are critical in producing a result where the doctor has full confidence in the quality of those results. The other area that has been very, very important, the use of connectivity, has been using what we call as data mining and analysis of electronic medical records to monitor the accuracy of point of care instruments. So this is often used to gather all the information and compare the results obtained from the point of care instruments and compare them with results obtained from the lab. So it's a very good quality control measure to assess the quality of point of care results with those obtained from the main lab. And you all know that in the last 5 years, what we are now seeing is a shift in which all information is undergoing what we call as digitalization. And so what is happening with this is that we now have health records which are now recorded electronically and in which you can have access to those results. And this has become very critical because your data management systems that I was talking about, they can provide a link to these electronic medical records as well as other devices. And as I've mentioned previously, this information provides a comprehensive understanding of a patient's medical history. So this is particularly useful in resource-constrained settings where the lab infrastructure is limited, and of course in emergencies where every second counts. Of course, this is also leading to what we call as an increase in digital density. In other words, the amount of data that is being produced on a daily basis by these point of care instruments. One of the other big advances that is happening in point of care testing is the ability to have these integrated technologies on one instrument. So, for example, you can have the paper technology, you can have the array technology, you can have the beads technology, and you can have the microfluidic technology all within the same instruments. And this allows for the analysis of proteins, exosomes, DNA analysis, as well as metabolites. And this is called as multiplex testing. And this is becoming quite a novel, you might say, achievement as far as point of care instruments are concerned. Because what is happening is through the availability of these multiple tests being carried out at the same time using different materials. When I say materials, I'm talking about using plasma samples, cells, and so on, and these being analyzed on the same instrument. This allows for the generation of multiple tests, which can lead to what we call as personalized therapy. So this multiplex point of care testing for the first time is allowing us to have results on the proteins, on the for example, what the DNA looks like, and other metabolites. So this is really having a big impact in the sense that it saves time and, of course, costs as well. And this is having an impact on personalized medicine. So what the Internet of Things has done is that it has having a big impact on what we call as personalized, preventive, and precision medicine. Some people call it pre-3 medicine, some people call it P4 medicine. But the impact that it is having is that it is changing to what we call as a change in patient behavior. So point of care testing as well as connectivity is allowing for a bi-directional exchange of information between the information provider and the patient. And this allows the patient through this connectivity to change the behavior. Whilst at the same time, it also allows the health provider to do what we call as a risk assessment. And you will all appreciate that risk assessment is becoming a critical part of how the health landscape is changing. So no doubt, point of care testing and this enhanced connectivity is having a big impact on treatment, on therapeutic evaluation, but very, very importantly, helping us to change our behavior. So one of the things that became quite apparent during the COVID epidemic was that we had a big enhancement of point-of-care molecular tests and infectious diseases management, what we call as precision epidemiology. So for the first time in recent times, especially in the last 4 years, point-of-care testing allowed for rapid sequencing and integration with bioinformatics, and this led to very rapid diagnosis, prevention, and treatment. And this had a big effect on what we call as population health. So by integrating this individual data, it could actually allow for very rapid identification of your microbes and the different types of microbes. And this had a huge impact on tracing of patients and indeed trying to find out what was the causative organism involved. So what has happened also from that COVID crisis was that the European Union became aware of the impact of point-of-care devices, and they put up this so-called ECDC RAN Europe project, which was started in 2019. And the whole idea of this is to use point-of-care testing instruments as well as other devices to integrate all this data. So they would integrate the molecular data, they would be able to trace contacts, and through connectivity, be able to communicate this information with healthcare centers so that rapid diagnosis and rapid tracing of patients can take place. And this has led to what we call as precision public health. So point-of-care testing now is playing an important role in this new era of what we call as precision public health, in which connectivity, point-of-care testing is enabling rapid diagnosis as well as tracing of patients. So how has it really made an impact in Africa? Yes, it's making an impact, a huge impact in Africa, especially where it has been instituted, because point-of-care testing also means that you need to have a supply chain in which is not just having your instruments, but you need to have a regular supply of the reagents. You need to make sure that they are stored properly. And very importantly, you need to have evidence that quality control and quality assurance procedures are being carried out. And linked to this is what we call as adherence. So once a diagnosis is made, especially, for example, in HIV, you need to make sure that the patients are given the right therapy and indeed they are adhering to the therapy that is being given. So this is where your point-of-care testing is becoming important because, as you know, point-of-care diagnostics lead to rapid testing. And if this is integrated with your connectivity, it can have a huge impact on your patient outcomes. And you all know that biosensors are here with us to stay. Phoebe all talked about monitoring of diabetes. There is no doubt that through biosensors, we can do continuous glucose monitoring. The point-of-care instruments allow for self-monitoring of blood glucose. And of course, we now have what we call as wearable sensors, in which you can analyze your sweat, tears, saliva through the skin. And all this information is transmitted via satellite to a transmitter, and you have this bi-directional exchange of information. So you can see that the whole monitoring and the landscape, health landscape, is changing because of this enhanced connectivity, as well as what we call as the Internet of Things, and of course the speed at which this information is being relayed and exchanged. So there is no doubt that what is happening now is an integration of different technologies and this involves what we call as self-monitoring and self-diagnosis. So whilst we would have hospitals and clinics as one form of monitoring and going to have yourself tested, you also have, on the other hand, self-diagnosis happening at home through the availability of these sensors. So you can actually see that through connectivity and the Internet of Things, that the whole health landscape is changing and having an impact on the behavior of the community. And lastly, we are also having an effect on what we call as e-health, in which everything is fully integrated. So you have your results, your paper-based results from your point-of-care instruments, and these are integrated into a data management system. And then you also have what we call as wearables that I just talked about, and all these are integrated into a single system where we have what is called as the e-health system, in which all this information, including your health records, your hospital health records, are integrated. And we have this emerging field of telemedicine. Lastly, I think it's important also to talk on IT security. This is becoming a big issue, and we need to make sure that the information that is collected is secure and not shared with people who are not authorized to do so. So in conclusion, connectivity and data management systems are essential tools for the successful implementation of a point-of-care testing service. And if you are planning to introduce it in your environment, this should be planned and costed for whenever such a service is desired. And there is no doubt it greatly reduces errors. It improves compliance to accreditation and regulatory standards. And there is no doubt that with enhanced connectivity, it will lead to fewer repeats ordered and make the service, as I said, more efficient and cost-effective. So thank you for listening and for your patience as well. And once again, thank you to Wondfo for inviting me to give this talk. Over to you.
Thank you, Professor Rajiv. Thank you for your wonderful presentation on the role of the connectivity and digital transformation in facilitating point-of-care testing in Africa. So, as we've heard from our full distinguished panel of experts, point-of-care testing holds immense potential in transforming primary healthcare in Africa. And we've explored its applications, navigated through challenges, and underscored the crucial role of intelligent connectivity. Now, to bring these insights into actionable focus, we are excited to introduce my colleague, our marketing manager from Wondfo, Mrs. Amber Jiang, who will shed light on how Wondfo point-of-care total solution is tailored to address the unique needs of primary healthcare settings. So, dear Ms. Amber Jiang, please share your screen whenever you're ready.
Okay, thank you, Phoebe. And this is Amber from Wondfo marketing team. It's really honored to join this webinar to discuss about the POCT application in primary care with all of our well-known doctors and professors. So my part today is to introduce the Wondfo primary care total solutions to show as a manufacturer how we see and what we can provide for the primary care. Just a very quick overview of our company. The name of our company is Guangzhou Wondfo Biotech. We established in 1992 with special focus in POCT. So up till now, we have 30 years efforts in the field of POCT already. And with all of our employees' efforts, right now we're the leading POCT companies in China and listed in Shenzhen Stock in 2015. Right now, our footstep has covered the over 150 countries and regions and established the 20 subsidiaries. So we can see since the very beginning of the establishment of the company, we're focusing on the POCT. And based on the features of the POCT product, one of our main application is in primary care. And we have noticed that the primary care has raising attention right now, especially after the COVID-19. The pandemic has created a significant challenges for the healthcare system, but also highlight the importance of the comprehensive primary care service. Many international organizations like WHO, like the World Bank, the UNICEF, they all express the positive attitude in developing the primary care. And they point out that with a strong primary network, it can save lives, save the monies, and to offer better health system to all of the peoples. So we have concluded the 4 general aims for primary care countries based on our experience. The first one is to improve the lab testing. The tests like the HbA1c mentioned by Dr. Getahun and the CRP mentioned by Dr. Mahmoud, and many other tests should be offered in the primary care facility. So with the accurate testing, the doctors can give the timely treatment accordingly. And the second one is the digitizing health, which I think the Professor Rajiv already gave very thorough introduction about it, and is one of the most important focus right now. And then is to standardize the diagnosis and treatment by issuing various clinical guidelines and enhance the supervision. And the last one is to extend the coverage of disease and population so that more people can enjoy more service in the primary care. So why primary care is important? It is the solid foundation for our healthcare system. It serves as a gatekeeper for the healthcare system. It can do basic screening and diagnosis and basic treatment for the common disease, and for stable disease like mostly chronic disease like diabetes, it can keep the track of the patient to do the monitoring and the management. And for the severe cases that cannot be handled in primary care, the primary care should refer the patients to the higher level hospital to let the patients to enjoy more specific care. So this way, we can have benefits like it will make our health system more efficient. Because for some common cases, it can be dealt with in primary care. So the higher level hospital can have more focus and resources to solve the complicated disease. And then it can improve the health outcome and control the overall cost of healthcare expenditure. Because the early and accurate diagnosis and treatment in primary care can reduce significantly of the patients getting into the hospital. Therefore, the overall healthcare expenditure can be reduced. And then is to reduce the healthcare disparity to increase the accessibility of all the populations all over the countries. And moreover, the quality care that provided by primary care is also very important. So the high-level hospital should do the educations and management and empowerment of our primary care facility at a regular basis. And as for the function of the primary care, we have give 4 examples here, which we think may be the 4 most important. Sorry, Dr. Mohammed, do you mind to mute your voice? So the first one is chronic disease, like the diabetes that introduced by Dr. Getahun, and then is the urgent case evaluation. And I put example here in China, it called a chest pain center network, which I think is quite unique. So this network combined the primary care and high-level hospital to let it become a network and with a very clear referral pathway for the timely diagnosis and treatment of the chest pain patients. And within this network, the primary care should be able to recognize, to do the initial diagnosis and differentiation of the transplant patients and to refer the patients to the high-level hospital. And then is the antibiotic guidance, which the antimicrobiome resistance is the global concern right now. And with a well-equipped primary care, it can greatly reduce the use of the antibiotic. And then is the infectious disease, which I cannot put more emphasis on it. If we have a very good primary care, it can help us to diagnose, to triage, and to do the real-time monitoring of the infectious disease. So for these functions, Wondfo can provide our product solutions, including 6 platforms here: the immunoassay FindCare, based on fluorescent, and the immunoassay Accurate based on the chemiluminescence, the dry chemistry, coagulation, and blood gas, colloidal gold, etc. So all these platforms can offer the tests like the HbA1c, CRP mentioned by our professors, and the cardiac markers, which are really important for transplant patients, and the kidney function, liver functions, which can help the overall evaluation, and INR can help the anticoagulant monitoring, and electrolyte, etc. And aside from the product solutions, we can also offer our information management system. So here we show the business model for our information management system. We collect the data in the primary care from different machines, different analyzers in the primary care. And also this system can help the daily management, daily operating of the primary care facility. And then data will be transmitted to the high-level hospital, the supervision hospital, to help the supervision and to do some data analysis. And then if required, the data can be further transmitted to the regional and national authorities to do the big data statistical analysis and to do the real-time monitoring. And basically, we have 2 general functions for our information management system. So the first is to help the general data management, to summarize and process and analyze the general data, including like how many tests we're doing and what kind of test, the quality control data, or the staff information or patient's information. And the second part is we can do the comprehensive disease management to monitor and manage different diseases. Like for infectious disease, we can monitor the whole region to kind of predict that within this region, which part has like most potential to outbreak in the futures. And then, for example, for antimicrobiome stewardship, we can record the number of tests we're doing, and we can also record the antibiotic that has been prescribed, so that we can have a clear understanding, the better understanding of the correlation between the tests we're doing and the antibiotic reduction that we are having. And we also offer the triple screen for our clients that designed for different scenarios. The first is the large screen. It can be used for supervision organization, like the MOH or the Center of Disease Prevention and Control, to visualize the data to show some key data indicators. And also we have the PC-based, laptop-based for each department or for each facilities to help the daily operating within the facilities. And then we have a mobile-based for individual, for example, for the head of lab or head of facility. It can be used when they work remotely or when there is urgent matters that need to be noticed. So in general, we present our Wondfo primary care total solution in the concept of the 1 square meter laboratory. So basically, this laboratory is a very small and compact mini laboratories. It has unified the technology platforms, which is our products, and the combination of the products can be designed based on our client's need. And then is the digitizing information system, which can help the daily operating of the primary care facility, and also can ensure your facility to stay connected within your network. to be connected with your supervision organization or with other primary care facilities. So we hope with our solutions, it can help you to beat the primary care as you expect. And here is like the photo galleries for our employees to show that we're already in actions. So many of our team are going to different countries all over the world to be with our customers, to understand what is the need of our customers in order to fulfill their expectation. I believe all of our team has one goal is to work for the better primary care and further for the better healthcare. So thank you very much. That will be all for my presentation. And if you have any questions about my part or any possible collaborations, please contact the email listed here. Thank you very much.
Okay, thank you, Mrs. Amber. So ladies and gentlemen, as we near the conclusion of this insightful webinar on advancing primary healthcare in Africa with point of care, smart diagnosis, timely treatment, I would like to express our gratitude to all our esteemed speakers for sharing their valuable expertise and perspectives. Now it's your turn to actively participate in the conversation. We are opening the floor to your questions. I'm going to select one question for each experts from the Q&A box. Okay, so first question is for Dr. Mabel. Dr. Mabel, are you with us?
Yes, please, I'm with you. Yeah.
Okay, so there is a question. How from Mr. Imad, how are governments and healthcare organizations collaborating to create policy frameworks that support the widespread adoption of POCT in primary care across the continent? I will tap the question into the Q&A box. So just a minute.
We had a big integrated meeting with the different stakeholders.
Dr. Mabel, I sent the question into your WhatsApp. Please check it and then give the answer to the audience.
Well, if you see the paper that we
you're ready to answer the question,
I will share it with people. We published it in 2019. It's gross knowledge.
Hello.
Well, going
Hi,
on the patient.
hi,
Can
Dr.
you hear
Mabel.
me, please?
Yeah, yes, we can.
Yes.
So, you know,
Okay.
how would you
I'm trying to
wrong results? Huh?
So get to the Q&A.
People don't know.
Is the question there?
Yeah, I sent the question into your WhatsApp. Please check it.
Okay, my own WhatsApp.
Yes, and I will repeat again. How are governments and healthcare organizations collaborating to create policy frameworks that support the widespread adoption of point of care in primary care across the continent?
Okay, well, like I said earlier, the POCT committee has started work, and we started the committee a few years ago. And I think it's just to establish, just like Rajiv has said, issues about POCT in Africa. And now we're going to think of collaborating with others, including government. And I think that is the focus of many societies. And in our conference that we're going to hold in January, we are going to sit together and look at the future of laboratory medicine in Africa. There we are going to sort out issues, but definitely governments and healthcare organizations have to collaborate to create policies. And during my talk, I said we would like professionals, industry, academia, and all that are stakeholders in health outcomes to come together so that we can have policies that it will influence the management of diseases among our community, in our communities in Africa. I do not know if that has helped. Yeah.
Okay, thank you for your answering, Dr. Mabel. So, so next question, it's for the Dr. Getahun. So please, will the blood glucose result correlated to the HbA1c results? Please answer this question if you are ready.
Yeah, yes. Definitely, yes. Yeah, the blood glucose level correlates with hemoglobin A1c. That's right. The only situation that should take care is in immediate hyperglycemia, especially recent hyperglycemia or new diagnosis of type 1 diabetes. The hemoglobin A1c may be normal, but the blood glucose may be very high. Otherwise, in a patient who is on treatment, then the blood glucose level correlates with hemoglobin A1c, and there is what's called a mean average glucose concentration, which you can interpret it. You see, for example, hemoglobin of A1c of 7 usually average blood glucose of 150. There are several tables to compare this, but you know, hemoglobin A1c is not always correlated with the blood glucose. There is what's called variability sometimes, but it tells you the mean average usually.
Okay.
If I
thank you.
Yeah.
Okay, thank you for your answering, Dr. Getahun. And the third question is for Professor Mahmoud. Okay. Professor Mahmoud, in what ways does point-of-care testing for CRP contribute to more timely and targeted interventions in clinical settings? And how does this technology enhance the efficiency of healthcare delivery, especially in scenarios where rapid diagnostic information is crucial for patient management? So
definitely it helps in the healthcare settings as it can guide us considering the immune response, what's going on considering the inflammatory process, is it going on to be worsened or everything will be okay. Apart from, it can guide us as well in order to decide, is it a must to start using the antibiotic therapy or it is not a must? This is a simple answer for this question.
Okay, thank you. Thank you for your answering, Professor Mahmoud. So the last question is for Professor Rajiv. So Professor Rajiv, given the limited internet access in Africa, particularly among a higher portion of the population and health facilities, what are the challenges and limitations of using artificial intelligence for a point of care in this context? So,
thank you. Yeah, thank you so much for that question. I think that's a very, very relevant comment. But I have just written an editorial on artificial intelligence and digital transformation of data in Africa. And that's true that one of the challenges is not having adequate connectivity. And even when the connectivity is there, we also have this problem with lack of electricity. As you know, that is also important. So On the one hand, it's not having power availability, and on the other hand, is not having adequate connectivity. However, what is important is that we have the Africa Union, who has put up a policy which says that, look, these are the areas that the governments of Africa must concentrate on. But the second thing that is also important now is that if you look at the availability of connectivity in Africa, it continues to rise. So we cannot say that because it's not there or it's limited, we should not continue with some of the other plans. No doubt, as Africa improves, as more money is spent on telecommunications, on electricity generation, as well as infrastructure, this situation is going to improve, no doubt. And I think even China, for example, is assisting the whole of Africa with some of these infrastructure projects. So I think it's not all gloom. I think there is a light at the end of the tunnel. I think things will improve. And as you all know, cell phones and smartphones are easily available in Africa, and they are becoming cheaper and cheaper. Over to you.
Okay, thank you for detailed answering, Professor Rajiv. Okay, I thank you very much to all the experts for answering the questions. And we will shout out your questions and send them to your email address after the session. Or if you have any questions about the webinar or our products after conference, you can send them to our email address, and we will focus on answering them for you.
Yeah, so I just, it's Prof. Erasmus here. I just want to thank Wondfo for inviting me, but also I want to say hello to Dr. Getahun. I think I met him in Johannesburg 4 weeks ago when he came for a conference on A1C and diabetes in Africa. So greetings to Dr. Getahun.
Hello, Prof. Rasmus. Hello.
Yes.
Yes, how are you?
So, yes, I'm fine. Good. Thank you so much to Wondfo for bringing us together on this platform.
Okay, thank you.
Thank you very much for professors and doctors to join us today.
Thank you. So after I will sharing my screen, and here shows the, okay, just a minute. Yeah. So if you have any questions about webinar or our products after the session, you can send them to our email address, and we will focus on answering them for you. And if you have any requests for certificate of participation or PPT material for this webinar, please send an email to, also, and with your name must have country and title to the following email address. So thank you all for being a part of today's webinar. As we conclude, I want to express our deep appreciation to our knowledgeable speakers and audience. Remember that the conversation doesn't end here. Stay engaged by exploring further resources, connecting with our speakers, and continuing the dialogue within your professional circles. Let's keep the momentum going in our collective pursuit of advancing primary healthcare. Once again, thank you for your active participation. We look forward to welcoming you in our future webinars. Wishing you all continued success in your endeavors, and have a great day. See you. Bye.
Bye. Bye then.
Thank you. Bye.
Thank you.
Just to say thank you, Phoebe. Greetings,
you.
Rajiv, and all speakers.
Thank you,
very much.
Professor Rajiv.
Thank you, Mabel. Thank you, Mabel, for those greetings. And we'll be in touch.
Okay. Thank you.
Looking forward to see you again.
Thank you.